Hello everyone. Today we're going to talk about fetal heart rate monitoring, or FHR. A couple of terms that we need to get out of the way. These monitors are either going to be external or internal. External monitors are going to be on the patient's abdomen. Internal monitors are fetal scalp monitors. Most of the time you'll see external monitors. Those are the most common one. These are all standard means of measuring fetal heart rate and fetal well-being. With these two monitors, we can measure two items. First one being, of course, fetal heart rate. Second one is going to be uterine contraction. Now, fetal heart rate normally is 120 to 160 beats per minute. Fetal bradycardia is defined as less than 100 beats per minute, and severe Brady, that's going to be less than 80 a minute. Normally there is some variability. Or fluctuations in fetal heart rate. That's mainly due to the sympathetic versus parasympathetic activity. Your fluctuations that are normal, or variability, is 5 to 25 beats per minute. Small variations, small variability, is usually good, whereas lack of variability is bad. That is either fetal distress, hypoxia, or fetal acidosis. When you are in the OB suite, you're going to look at the baby's heart rate strip. That's their rhythm strip. So we'll just draw that out. You also have another strip below. That's going to be your maternal strip. We'll label this fetal heart rate. This is your uterine. Or contractions. Let's draw out our uterine contraction first. With each peak, the uterus is contracting. And uterus contraction should be regular, 3 to 4 minutes apart, and each lasting 1 minute duration. So these are regular uterine contractions. The peak of each contraction, for some terminology here, the peaks of each contraction is called acme. Not the roadrunner and the coyote. For some reason they like to call it acme. The lowest point of contraction, or A cells or D cells, are called nadir. And that goes the same for fetal heart rate. Now let's look at variability. Fetal heart rate 160, 120. We'll define bradycardia as 100. When you look in straightly at variability, you want to see a fetal heart rate that has some variability, fluctuations. This is minimal. If you get to the point where it's absent, remember, absent's bad. We like fluctuations. Also, you can have moderate variability all the way to marked variability. I mean, that's just going crazy. Baby's active. That's how we're going to interpret it according to its variability. All right, let's relate this to the uterine contraction itself so we can define whether these accelerations and decelerations are late or they are early. We'll start with earlies or early decelerations. So we have variability right here. Baby's doing well. And before the uterus contracts, we have a dip in the heart rate, and it goes back up to normal, to baseline. Still have variability. And another dip, but we go back to baseline. Now, how do we determine if it's early or if it's late? The peak of each contraction at the acme point, draw a straight line up to the point where the fetal heart rate is. It is before the uterine contraction. Again, we'll draw it straight up. So these decelerations are early because they happen before the uterine contraction. Early decels. Now, early decels are generally due to head compression. From the fetal head being engaged, ready for birth. Variable decels, we'll just draw a second line. Now, variable decelerations can occur at any time, and they're usually benign, not problematic. They can happen before contractions while the uterus is relaxing. Due to cord compression. So we're talking about deceleration. Accelerations are okay. We have some, that's going to be marked in green. So we have variability here. And goes up, comes back down, up, down, up, down. All right. Accelerations are okay. It's normal. In fact, we like acceleration. What we don't like are late decelerations. Late decelerations occur at the onset or at the peak of the contractions. Let's draw our line here. So we have some variability. Now here's the peak or the acme point, and we're going to have fetal bradycardia or decelerations. And this one, we've reached our acme point and fetal variability or fetal bradycardia decels again. So these are lates. Late decels are problematic, so there is a problem somewhere. In this case, most of the time is placental issues. I'm going to teach you a mnemonic here. Veal chop is what I'm going to teach you. V. V stands for variable. When you have variable decelerations, it's due to cord compression, most likely. When you have earlies, earlies are due to head compression. Remember that? Acels, acceleration. They're A-OK. Lates, remember they're bad. They are placental problems. The treatment for lates are you change the position, maternal position, right? Which position should that be? Left uterine displacement. give mom oxygen. And if your patient is on Pitocin, you want to stop that. I hope this helps. We will review this in class also. Thank you.